So, ladies and gentlemen, thanks again for joining us tonight. It gives me great pleasure to invite you to the Cxbladder Triage webinar this evening. So, as far as how the guidelines could be implemented in your practice, why don't we start with Dr. Klaassen and ask you about the risk stratification strategy that you use now and how it's evolving over time.
Yeah, I think, Jay, when we look at the AUA guidelines, we've been begging for a level one evidence urinary biomarker, and I think we've had a history of biomarkers that have been average at best, and so I think the trial that you mentioned, the Strata trial, and the AUA recognizing that this is the best quality evidence out there, kind of led to this level one sort of grade A evidence for AUA. So I think when we talk to patients about this, we have the confidence that we don't want to do too many cystoscopies if we don't have to. We don't want to miss anything either, right? So I think we talk about getting into that low risk appropriately, and this is what this test does. There's a lot of noise in the intermediate, but if we can get somebody to low risk based on the Cxbladder triage, that certainly is helpful. And it's been difficult to do that, in that 45-year-old female who has maybe smoked for 5 years, who had microhematuria from the primary care physician. Ultimately, I don't want to have to do a cystoscopy on this person if I don't have to. I have too many patients to see. I think Ron mentioned earlier the workflow. This has really helped with the workflow of really appropriately cystoing people that need to be cystoed, but then using the time in the clinic to see somebody else who has a 15 centimeter renal mass, for example. So I think it's about efficiency. Certainly patient feedback has been excellent in terms of the ability to not have to do a cysto if we don't need to, but also at the same time, if the test comes back with a higher risk, then we're able to have that discussion and ultimately have the cystoscopy. So it's been very helpful.
That's great. How about you, Dr. Scarpato? How are you implementing the new guidelines?
Yeah, I think first it's important to consider the number of patients out there with microhematuria. It's not an insignificant number, and we are, as urologists, are certainly seeing a fair number of these patients, and doing a cystoscopy on all of them, not only is it not feasible, but it's also maybe over treatment, over investigation for many of these patients. And I think this guideline, and actually several other guidelines, are really focused now on de-escalation of workup and de-escalation of care for appropriately selected patients. And the benefit, I think, to the patient is significant if we can safely rule out an invasive procedure that we know comes along with some amount of discomfort, which is different for everyone.
Dr. Scarpato and Dr. Klaassen, I love how you're able to touch on so many different aspects of clinical care that this really touches. So Dr. Liu, tell us your thoughts about the guideline implementation now.
The new guidelines, are, as I mentioned, are more closely aligned with how we sort of view the world, and now they're categorized as intermediate risk patients that get either cystoscopy or can now have this urinary biomarker test performed. In our hands, by using this test, we're able to eliminate 3/4 of the patients from having to undergo invasive testing safely. The other tests that we looked at and dabbled with for the last 10, 15, almost 20 years, the negative predictive value was not reliable enough for us to actually change practice. And that's really where I think the game changer came in for us. If the test says you don't have bladder cancer, you don't have bladder cancer. And the important thing in our hands as we tested for utility is that the doctors trusted it, number one. If they ordered the test and the test came back negative, 97, 98% of the patients did not undergo cystoscopy. It really proved to us that our doctors trust the test. Secondly, the patients really appreciated and trusted the test. In our hands, for all comers that come to see us with hematuria that we book for cystoscopy, less than half of them actually will come in and see us for the procedure, right? As our study sort of proved out, the patients really appreciate having an extra level of scrutiny to decide whether or not they need an invasive test. And we actually got almost twice as many patients come in and actually undergo the workup. And that was a big deal for us as well.
That's excellent, Dr. Lee. You brought up so many great points. Dr. Goldfischer has a little bit of a different practice background, being the LUGPA president in a LUGPA and everybody else being the university-based or Kaiser-based system. Please, Dr. Goldfischer, share your thoughts.
Sure. Thanks very much, Jay. So I think Zach and Ron both made great points. We all have more business than we know what to do with. As president of LUGPA, I've been able to travel around the country, and I've seen a lot of stuff, but the one thing I've never seen is an empty urology waiting room. I don't think it exists. And Kristen makes a great point. This is an invasive test. And when you talk to a cystoscopy, particularly to a young male, they cross their legs and they're like, really? Do I have to have this done? Do I really have to have this done? And they start to ask about anesthesia, which is just not practical, right? And, so we saw during COVID, where we were limiting our office visits and our office procedures, we really had to be judicious at that time as to who underwent a cystoscopy in our office because of all the restrictions that were placed upon us. So I think this test is really just an extension of what we all started to realize during COVID. You can't do a cystoscopy on everybody. And I think the gastroenterologists are a couple years ahead of us. While it's not an exact comparison, a lot of patients who are very low risk for colon cancer choose to undergo a Cologuard test instead of a colonoscopy. They want to avoid the anesthesia, the day off from work, the prep, and for most low-risk patients, a Cologuard is a reasonable option instead of an invasive colonoscopy. So that's, in my mind frame, that's how I'm looking at this test. For low-risk patients, this is our version of a Cologuard. Allows improved office flow. As Zach pointed out, we can see the patients who really do need to be seen and really need a workup, but we're not forgetting about these patients. They're still getting an appropriate test and appropriate workup. And yes, if it comes back positive, obviously, we're going to change our management. But for most patients who come back negative, they can avoid a cystoscopy and avoid an invasive procedure.